I'm Jeff Copeland. Been active with this organization for quite some time, and enjoy this meeting very much. It's a privilege to be here, and it's a wonderful group of people actively engaged. As in several past previous meetings where we talked about IANPHI, we had also sessions on CHAMPS. It's an unusual study, an unusual project, and you'll learn more about it and the current situation in the course of this session. We have chairing the session as a principal investigator on CHAMPS, Cindy Whitney, and she'll be up fielding questions and keeping the discussion going after an introduction to where we are now 7 years into the CHAMPS program. And for those who aren't familiar with it, CHAMPS stands for Child Health and Mortality Prevention Surveillance. I'm proud of that acronym, having played a role in thinking it up. Let me introduce some of our panelists. Some of them are virtual and are online, but haven't dialed in yet, so that will occur hopefully during the course of the discussion. We have online from South Africa, Natalie Mayette, who's Deputy Director of the South African National Institute of Communicable Diseases and has been a very active member in our organization and still is. Tamina Sharan from Bangladesh, where she's Director of the Institute of Epidemiology, Disease Control and Research. Mohammed Vandi from Sierra Leone with the National Public Health Association. And those are the virtual attendees, those three. And then present here in person is Professor Amer Iktam, who will be speaking about their new Pakistan National Institutes of Health entry into this area. And Dr. Professor Ikram is Executive Director of the Pakistan NIH. We have the Director General of the Nigerian CDC and Dr. Dayo, and many of you have probably met him earlier in the course of the meeting and has been an active participant in this meeting. Elias Jani, old friend of the organization and Director General of the Mozambique National Institutes of Health. And Mesai Halu, who was Vice President of Hawassa University and now has left the sheltered academic life of the university to engage with 150 million people of Ethiopia and leading the Ethiopian Global Health Institute. So we've got a wonderful group, and as always, wish we could have more time with each of them up here, but I can help that by getting off the stage and getting to the meat of the issue here. So Cindy, you want to come up and take on?
Good morning, everyone. As Jeff said, I'm Cindy Whitney. I'm the Executive Director and PI for CHAMPS. It's a really pleasure to be here. It's been a great meeting, and I've enjoyed meeting so many of you. I'm going to talk about child health and mortality prevention surveillance. Now, I don't need to tell this group that usually when you talk about a surveillance program, you want to include all the people in your country that are at risk. You want to have a simple case definition. You want to have a diagnostic test that's widely available and straightforward. Well, CHAMPS didn't do any of that. It did the opposite. It decided to focus in specific catchment areas, use very, very rigorous diagnostics that are incredibly complicated and required a bunch of training. But what we do get are very specific information about causes of death. So what I'm going to talk about is what we're finding now several years into the program about what really causes stillbirth and child deaths in high mortality settings. And then we're going to have a discussion with the people that Jeff just introduced about how this different kind of surveillance data can be integrated into other surveillance data to inform public health policy. Now, this is a figure that's often quoted and shown about causes of death in children under 5 years in high mortality settings. In this pie chart, the yellow are neonatal causes, and the rest of the graph is causes in infants and children. And you hear about preterm birth complications, you hear about pneumonia and diarrhea being leading causes. Now, but this kind of information generated from modeling really has some limitations. There are several reasons that this kind of information is unreliable. For example, many deaths can occur outside of hospitals or after very short hospital stays where the clinicians don't really have a chance to evaluate what's going on with a child. Diagnostic tests might not be available for everything that clinicians would like. Death certificates aren't standard in many places. And some places do use systems of using verbal autopsies, which might be helpful on a population level, but for individual deaths, it's known to be inaccurate. And the figure also excludes information on stillbirths, which not a lot of studies have examined, frankly. And the other limitation of this figure is it implies that each death really only has one cause. And you'll see from our information that that's not often the case. So CHAMPS has a vision where evidence-based interventions offer every child an equal chance to thrive. Our mission is to save children's lives by collecting, analyzing, and sharing accurate, timely data about the causes of child mortality in regions where it's highest. We have 3 overarching objectives: to track the definitive causes of child mortality in sites throughout sub-Saharan Africa and South Asia, using what's called minimally invasive tissue sampling, which I'll talk a little bit more about in a minute, but it's basically a series of biopsies of key body parts to help us understand what happened to each death. Our second objective is to produce and disseminate high-quality data to inform policy and public health action. And the third objective is to enable sites to use the investments to prevent mortality in our so-called data to action objective. Now, it's clear that for these last two to really work, we have to work closely with our National Public Health Institute partners, especially to generate interventions to prevent mortality. So this map shows where we're currently working or about to work. We're in the green are our existing sites that have been enrolling now for some time: Bamako, Mali, Makeni area in Sierra Leone, Harar Kursa area in Ethiopia, Kisumu in Western Kenya, Kalamani in the north of Mozambique, Manisa in the south, Soweto in South Africa, and the Balakandi region in Bangladesh. We're now starting, we're now planning for enrollment in 2 areas, Bauchi in the Calabar region in Nigeria and near Karachi in Pakistan. This is our organizational chart. Our primary funder is the Bill and Melinda Gates Foundation. We have a program office based at Emory University. There's a collaboration between staff at Emory, IANPHI staff, CDC, and staff from the Task Force for Global Health. And then you can see here that the 7 sites have, some of them have multiple most of them have multiple partners helping to operate the surveillance. Now, this looks like a top-down approach on paper, but we're doing everything we can, and increasingly so, to have a disseminated leadership model with a focus on increasing network-wide activities that are led from the sites. We have a network steering committee where the site leaders are involved in key decisions. We are now starting to operate key parts of the program, for example, our health and demographic surveillance system, from having sites actually lead that for the whole network. We also are putting some of our leadership positions in Africa and Asia, and site leaders do direct important activities, for example, our quality of care working group. Now, on to the complicated methods of CHAMPS. So CHAMPS, because we're trying to identify deaths quickly enough that we can collect specimens before a child is buried, there has to be strong community engagement. first of all, to understand the practices and customs around death, but also to get buy-in from community leaders and from families who might potentially participate in CHAMPS. So before we do anything, there's a qualitative body of work that's done with social behavioral scientists to build community buy-in for the program. Then we launch surveillance for mortality, for deaths. And if we can identify a death within 24 hours, and obviously before burial, we collect a series of biopsy specimens, blood and CSF, and some swabs that then undergo a bunch of laboratory testing. We also do verbal autopsies with the family some weeks after the death occurs, and we go to the clinical records and see if what's there that can help us with our diagnosis. The tests we do routine culture on the blood and CSF, and then we do a series of PCR reactions. We have a specialized card that detects over 120 different pathogens. And then the tissues are examined both by local pathologists, and if there's a need for some reference work, are sent to the pathology lab at CDC. Then all of this information comes together to what we call a determination of cause of death panel, or DECODE panel, where local clinicians, epidemiologists, pathologists will look at all the results and come together to make a diagnosis. So unlike other surveillance systems, which are straightforward, we have a whole panel of people that reviews the information to try to figure out which of our many case definitions this meets. And then we feed back the information to the community, to the public health leaders, to the NPHIs and others to hopefully be able to act on what we're finding. And throughout this whole time, we have our teams working in the community to make sure everybody's aware of what's going on. Now, the data that are pulled together by the DECODE panel are pulled into what's essentially a typical death certificate format. Every child is assigned an underlying cause of death, which is the health event that led to the death initially. If there are other things that occur along the way, they might have morbid causes of death. And the health event that occurs right before the child dies is the immediate cause of death. For stillbirths and neonates, often there is an issue with the pregnancy or the care that was delivered in the pregnancy. So we also look at what's called the ICD-PM, or maternal conditions. So let me give you an example of what CHAMPS data look like. This is a case, it was a stillbirth female, 35 weeks, estimated gestational age by LMP. The weight was normal, 3.8 kilograms. The mother was a 20-year-old woman who was HIV positive, but she was on antiretroviral therapy that was diagnosed, and she was diagnosed prior to her pregnancy. The baby was one of a twin, and the mother had 4 antenatal care visits. On postmortem testing of the baby, HIV, malaria, and TB testing was negative. The other twin was born alive, had a relatively good APGAR, but was a little bit on the low birth weight side. When the clinicians examined the case, they felt that the stillbirth was the result of obstructed labor. However, when we tested the tissues from the baby using our PCR panel, the baby's tissues were positive for Treponema pallidum, or the cause of syphilis. So here's what the tissue in this case looked like. We've got liver, lung, brain, and placenta, and the red squiggles are Treponema pallidum. So you can see that clearly this baby's death was a result of congenital syphilis. The mother and the twin were tested and treated, and when you looked at the history of this woman's visits, she had 4 antenatal care visits. The syphilis test kits were out at the time where she would have normally had that test. So it was a missed opportunity to prevent this death. So now let's get to what we're finding so far. Now we're at the start of year 8 of our program. We've enrolled over 9,400 deaths. We have MITs completed on over 5,000. The drop off between the 9,000 and the 5,000 is usually due to the fact that we don't get to the death in time. If we don't, we do try to collect some information, whatever's available for that child. We have MITs completed on 5,000, and we've gone through the full decode process on nearly 4,000. Now, when you look at these pie charts, you remember the original one that's often quoted where 40% are neonatal deaths and the rest are infants and children. Well, you can see that the dark green part of our pie charts are stillbirths, which are fully a third of all the deaths that we're identifying. So stillbirths are an important part of the whole child mortality picture. Neonates are a little more than a third of who we enroll, and infants and children are about 28%. So let me show you now a series of graphs like this one that talk about the underlying cause of death. Now, you remember that we can have an immediate and comorbid causes as well, but I'm showing you here the underlying cause of death. This is for stillbirths, and I think you would agree with me, it's not a very interesting graph because 73% are one diagnosis, perinatal asphyxia hypoxia, which just means that this was a normal baby who died because they weren't delivered when they needed to be. Something went wrong with the pregnancy, with the delivery, and this was an infant that was otherwise normal. You'll see that we do have some infections, congenital infections like the case I just showed you, and we see congenital defects in about 7% of our deaths. Now, interestingly, that 7% is pretty typical regardless of age group. That's about the role that congenital defects play in child deaths. For stillbirths, we do have a few undetermined cases where we just can't tell what went wrong. And that percentage is a little bit lower in the other age groups. Now, the interesting thing about stillbirths is 83% only have one cause of death, which is different than the other age groups that you'll see. It's much more complicated. This is the graph for neonatal causes of death. We still have the perinatal asphyxia hypoxia, 29% in the middle purple box. But now you see preterm birth complications are really the most common underlying cause of death. We do have more infections in this group. The pink box is infectious causes of death. And you'll see again the congenital birth defects. Now, with neonates, it's interesting. The babies that die shortly after they're born are generally normal birth weight babies. They don't have something else going on, but they're the perinatal asphyxia and hypoxia. Now, the deaths that we're finding that live past those first few days are generally preterm births who then go on to have other problems, respiratory distress syndrome, sepsis. About 61% of neonatal deaths have more than one cause of death, and 35% have a complicated course of 3 or more. Now, with both of these age groups, as you can imagine, conditions with the pregnancy, conditions around the delivery have important roles to play. 78% of stillbirths and 64% of neonatal deaths are determined to be related to something that went wrong with the mom's pregnancy, with the mom's delivery. The most common things that we note are issues with the placenta, placental abruptions, for example, or cord complications, the cord's wrapped around the neck. We have a lot of maternal hypertension, eclampsia, preeclampsia. We have obstructed labor or other complications, 8% chorioamnionitis, and in 5% of our deaths, there's a multiple gestation. As I mentioned, a lot of our preterm births, their lungs aren't ready to breathe. They develop respiratory distress syndrome. Here's you can see in the pathology picture on the right, I don't know if you can make out the arrows from where you're sitting, but they're pointing to hyaline membranes, which is how you diagnose respiratory distress syndrome definitively. 29% of all of our neonatal deaths have this. And of preterms, 2/3 will develop this. Now, in some places, if you have artificial surfactant you can give and you have respiratory care that can support these lungs, these children can grow and survive. But a lot of the places we work just don't have those things available. Neonatal sepsis, I want to show you what we're finding around that. In this graph, the distribution of causes for stillbirths are in green. Yellow is early neonatal deaths from infections, and purple are after 72 hours of hospitalization. And I don't know if you can make out the names, but Group B strep and E. coli are what you would expect among the early deaths, and that's what we're finding. Among the late deaths, unfortunately, hospital-acquired gram-negative infections are what comes into play. And the two big bars on the right are Klebsiella pneumoniae and Acinetobacter baumannii, pathogens that can be really highly resistant and difficult or impossible to treat in the facilities where we work. Now here's the distribution of causes of death for infants and children. You can see in this age group, we get a big shift with the pink or the infectious causes now being the predominant underlying cause of death. We've got malaria 12%, HIV 11%, respiratory infections 8%, some diarrhea. Malnutrition is a very common underlying cause of death in our population, 18%. And you can see a range of other things up here. Now in this age group, nearly all the kids, at least 73%, have more than one cause of death, and 44% have 3 or more. So we do get some healthy kids that die of one thing, but the more common story is there'll be an unhealthy kid who goes on to develop a second or third issue, and then they can't survive. Now let's talk about some of the more common causes in this age group. Malaria in the sites where it's prevalent is incredibly important. In Kenya, it's 32% of deaths in this age group have a malaria infection somewhere in their causal chain, not necessarily underlying, but somewhere. In Mozambique, it's 17%. Now those data are mostly from the south of Mozambique. We're going to be working in the north, and I'm curious to see if that number will change. And in Sierra Leone, it's fully 43% of our deaths have malaria somewhere in their causal chain. We were surprised about the amount of HIV we were finding. As I mentioned before, we have 11% of deaths with HIV in the causal chain. It's usually the underlying condition. As you know, with HIV, these kids go on to develop other infections. And the common other infections we're finding are CMV, Klebsiella, pneumococcus, pneumocystis jirovecii, the ones that you're familiar with. What we identify is that this is obviously a failure of prevention of maternal to child transmission programs that each of our countries have. Only 20% of the children had received antiretroviral treatment prophylaxis after delivery, and only 30% of the mothers had received ART during pregnancy. So that's a big problem. Now, of the deaths in children who don't technically have HIV, HIV is still contributing through HIV exposure. 16% of our deaths in children without HIV infection have documented HIV exposure, meaning they're born to an HIV positive mother. Pneumonia is not a big underlying cause of death, but when you consider other positions in the causal chain, it's very important. Nearly half, 46% of post-neonatal deaths have pneumonia in their causal chain. When you look at, okay, well, what was the underlying condition for these children? It's things like malnutrition, HIV, sepsis, or congenital defects. Now, we're taking lung tissue and examining it directly using really sensitive PCRs that look for a bunch of targets using pathology. We are finding a lot of organisms in the lung. We don't attribute everything to the cause of death. You really have to have evidence that you see an immune reaction to these organisms. So only about half of the organisms we see in the lung end up being called causal. But nonetheless, most children with pneumonia have at least 2 attributed etiologies, and we only have about 12% where we can't find an etiology. The table on the right is the most common etiologies. Interestingly, gram-negative Klebsiella pneumonia is the single most common cause. We get a lot of non-typable H. flu. Strep pneumoniae is the second most common cause, which surprised us because all of our countries are using pneumococcal conjugate vaccines. And you can see there's a range of stuff here, and I'm happy to share these slides if people would like to take a closer look. Now, I've mentioned Klebsiella pneumonia a couple times now, neonatal sepsis, pneumonia in infants and children. It is by far and away the most common single bacterial cause of death that we're finding. In fact, we detect it in 30% of all of our deaths, not necessarily deemed causal in all of those, but it's detected very, very commonly. It's in the causal chain for 14% of our deaths if you just look at every age group altogether. And most of those deaths will have sepsis or meningitis. Now you're thinking, okay, well, is all of this healthcare related? That's a healthcare related bug. But when we look at deaths in kids that have never been to the hospital, for our knowledge, we also see it in those kids. So it's clearly out in the community in our catchment areas. And this organism is frequently antibiotic resistant. The figure on the right is some of the isolates we have that we tested for resistance. Let me just summarize the figure for you. Dark purple is bad. That means it's resistant to the antibiotic. The antibiotics at the top are the usual beta-lactams people will have available in their hospitals. And you go down to the bottom and it's usually susceptible to drugs like imipenem and meropenem, but are these available? That's a question. So malnutrition also very important. It's in total in infants and children, it's 29% of all of our deaths. When you have malnutrition as your underlying condition, it makes you much more susceptible to sepsis, pneumonia, those infectious diseases, and that's what we're finding. Even malaria is a common cause of death in kids that are malnourished. Now, I've shown you some of the results from our cause of death work, and let me now move on to show you some of the other things we're doing to move from data to taking action to prevent deaths and to use the platform for other kinds of work. So CHAMPS, because we have this strong community engagement component and close links with our families that participate, we're able to link those households to other essential services, social grants, vital documents that will hopefully allow them to prevent future deaths within their family. We do know that once women have participated in MITS, the CHAMPS procedures, and we go back and tell them what happened with their baby, they're much more likely next time to participate in prenatal care and to advocate for the appropriate care they need. We also do grief counseling to help bereaved families deal with the trauma they've gone through. We were COVID-19 threw our project for a loop like it did to everyone. We had to shift from doing regular CHAMPS work to helping however we could with the response. We did a lot of community-centered responses, trainings, and education. We also converted our labs to COVID testing labs. And in fact, in 3 of our countries, the COVID lab was designated as a national testing hub for their districts. We started to do COVID testing on our deaths. As expected, we weren't finding a lot of COVID in our deaths. Only about 2% have been positive during the pandemic, and only 5 of the deaths that were ultimately tested positive were even thought to have COVID in the causal chain. And we've done a number of studies to look at the COVID-19 surveillance, the epidemiology of the pandemic. The figure on the right is some work that was done in Ethiopia where as part of the HCSS, they added some questions about COVID. And as expected, a lot of the families noted increases in food prices, noted job losses, noted problems with inflation. So we were able to actually look at some of the impacts of COVID on families. We also did some rapid assessments using our qualitative teams, SBS teams, that looked at perceptions around COVID and around COVID vaccines. At the time we did these surveys, there were already widespread knowledge of prevention practices like masks and hand washing. That was great to see. But 80% of the people that participated in these qualitative assessments said health services had worsened in general during the pandemic, and 94% indicated a negative economic impact. For COVID vaccine perceptions, 24 of those interviewed out of 81 had already been vaccinated, and 53 were willing to be. So overall, a lot of vaccine acceptance. And you can see in the balloon some of the comments people made. Would you be willing to take the vaccine if you could still become infected but not have a severe case of infection? And people understood that, but had different opinions on it. So our decode panels for each death also look at what went wrong and could it have been prevented. And it's not surprising that the vast majority of these deaths are deemed preventable with interventions that already exist in our sites. Here's a figure from an analysis that was recently published about neonatal deaths. And it's clear that better antenatal care and obstetric care, better clinical management of the baby, and very importantly, infection prevention are what was deemed important to prevent neonatal deaths. Now, I've just told you these giant buckets, improve obstetric care. What does that really mean? It's not a root cause. There's so many pieces of that. It's an important thing that CHAMPS is now doing is to try to more systematically look at below the surface to try to get at the root causes of what went wrong with care. We're also launching pregnancy surveillance. It's up and rolling in a couple of sites and others are coming online. I think given how many of our deaths are stillbirths and early neonatal deaths, this is really going to provide some insight into how things could be better. And it's clear that, the main way to improve survival for mother and baby is through having delivery by a skilled birth attendant in a facility. But in some of our sites, we hear that in the communities that women avoid delivering in facilities because the care is often disrespectful, facilities are poorly kept, and lacking needed resources. So we're really trying to get a better handle on what's going on and how it could be improved. I told you about congenital defects in general in our study. We found a really interesting situation in Ethiopia with neural tube defects. This is a graph of the rates of neural tube defects in children under 5 in CHAMPS. The red line, the red hash line going forward at 5%, or 5 per 10,000 births rather, is sort of what you would expect in a population if you had full implementation of folate supplementation in your food. And most of our sites are at that or slightly above. Ethiopia, however, was an outlier with a lot more neural tube defects. EPHI was already aware of this issue in their country, and we're now actively talking about these data and trying to collaborate with them as best to give them the information we can. They are already working on a folate fortification with salt, and hopefully we'll hear more about that in the discussion in a minute. Okay, under nutrition and micronutrients, we're trying to do more to understand exactly in which way kids are malnourished. We've done a pilot with vitamin A levels, looking at vitamin A in liver tissues, and about 34% of kids are vitamin A deficient at the time of their death. We're now starting a plan to examine the prevalence of other deficiencies for micronutrients in pregnant women and in infant and children. We're also branching out a little bit to look at deaths in adults. There was a recent study published in Lancet Global Health using verbal autopsies that said that malaria was the leading cause of death in Sierra Leone in all age groups, including adults. This is in contrast to the widely accepted understanding of malaria deaths. So our primary objective then is to look at the contribution of malaria in deaths, and we're doing that in Kenya and Sierra Leone. We have a lot of CHAMPS data and resources that I'd like you to be aware of. We do share data routinely with a lot of partners. We've collaborated with WHO on calibrating the verbal autopsy results, because in all of our deaths, we have both verbal autopsy information and information from CHAMPS, so trying to make that more accurate. And we do get a lot of data requests. We've had 80 in 2021. Here's our website, champshealth.org. You can go there to see real-time causes of death, peer-reviewed publications, et cetera, et cetera. Everything is there. So what's next for CHAMPS? As I mentioned, we're going to be expanding into new populations in Nigeria and Pakistan, and trying to maintain the high-quality surveillance going on elsewhere. We're continuing to increase the shift of leadership to the CHAMPS network sites in Africa and South Asia. We'd like to do more with our platform infrastructure to engage with new partners and to pursue scientific priorities. And with national public health institutes, promote the use of our findings to improve health through better communication and dissemination of results, and to work with partners to act on findings. So I'll stop there, and I just want to acknowledge the CHAMPS, the families that work with CHAMPS, and the communities that make our work possible. Thank you. All righty, well, why don't we take a quick stretch break while our panel comes up here for the discussion. Okay, let's go ahead. Does somebody have the second microphone? We can move this one, okay. Okay, so Dr. Johnny, let me start with you with this first question, and then others please join in. So as I've described, CHAMPS is from specific catchments. We have surveillance data that are not your typical surveillance data. You know, how do you think about that when you think about all of the data that you need to pull together to really know what's going on with the health in Mozambique?
Right, thanks. So I can maybe just tell a little bit of our experience on how we have been dealing with with data from CHAMPS and also from similar projects in other areas. So in a few years back, we set up a virtual platform called the National Health Observatory. And so that's a virtual platform. The secretariat sits at the institute. And then we have like several working groups. One of the working groups we have is on mortality. And this group is so important because in our context in Mozambique, the vital statistics are not really readily available. So you have to rely on different sources of data to try to make sense of what's happening in terms of mortality. So in this mortality platform, we have several contributors to the platform. We have, for example, a survey, a community-based survey that we have been running at the Institute for many years called COMSA, that gets data from verbal autopsies in the community. We have whatever data we can get from the vital statistics that the Ministry of Justice runs, so they are part of the platform. We have data on hospital deaths that is provided by the Ministry of Health. So several sectors of the Ministry of Health are part of that platform. We have data from registries at the cemetery level, which is run by municipalities. So they are part of the platform. And then we have the National Institute of Statistics that has data from census, and we have CHAMPS. So this working group, they meet 4 times a year and share the data that they have and analyze it together. So it's a good way of not only bringing the data together, but bringing the people and the skills together, so that everyone together can make sense of what the overall data of mortality looks like in the country. And we this year, most probably in January, we will have a comprehensive report. For the first time, Mozambique is going to get a comprehensive report on what the situation of mortality is according to all these sources of data, which will include the CHAMPS data. So that's how we have been dealing with this. It's a beautiful story to tell, but there are challenges, of course. Bringing people together and bringing data together is not always easy. There is a lot of I don't know what word to use here, but it's you need to do a lot of negotiation. So it's sometimes difficult to navigate all these institutions, egos, personalities, politics. But I think the work that we have been doing on this for the last 4 or 5 years is paying off now, and we have a system that runs smoothly. Thank you.
Great. Would anybody else like to weigh in? What about our new partners from Pakistan and Nigeria? Do you have any thoughts about how this might work?
Thank you so much. First of all, I'm quite fascinated because I've recently been exposed to the CHAMPS, and I must say you are the true champs, frankly speaking. We realize the problems in the developing countries, and unfortunately Pakistan, being a developing country, is among the topmost neonatal deaths and infant deaths, which in the present modern day science doesn't click to the mind. Well, within the country, we do have several systems. We have the federal ministry and the provincial governments, and underneath there is a system of tertiary, secondary and primary care hospital. But going beyond that is the basic health units, which stands responsible for all these things. We have a well-developed network of lady health visitors, which have performed immaculately over the years. They have remained involved with vaccination, with the COVID vaccination, with the polio vaccination, and so many other things. And then the community healthcare workers. Some time back, health regulatory commissions have also been inducted, and now their domain comes for this neonatal mortality. The data comes up mostly through the lady healthcare workers, through the basic health units, and we still have in our country the home delivery system as well. So it's quite fragmented. The thing is, definitely we understand the causes. The causes are similar, the preterm, perinatal, antenatal, and the postpartum care. Definitely malnourishment is one of the most important aggravating factors for these. So we need to be very precise as far as the infections are concerned, and as already said, so many normal babies just dying during the delivery time. And that's not what is expected in the modern day science and modern day medical developments. So that is the area we would be very keenly looking forward. We are excited to join this project, as we understand, starting from Karachi. And as for the National Institute, we have a new institute underneath now, which look after the maternal and child health. And we would be keenly looking forward, because this is the precise data, and this is what we need for the country. And so that we take the analytics to the ministry in a very palatable form for the evidence-based policy, and that's what is lacking in this field. And we would be we are quite excited, and thank you so much for the great job that you're already doing. And so we would be again would like to be part of your team for getting much more precise information as we are doing right now.
Cindy, can I add one thing?
Yes.
Sorry, I need to add a little bit of context, because it might be different in other places, is that in Mozambique and in many other countries on the African continent, most of the mortality happens in the community. So the hospitals it doesn't get into the information system of hospitals. So they happen in the community, the burial will take place in the community. And so the health system has, unless you have a community-based system, the health system will not learn about the mortality and will not learn about the causes. And that's why it's so important that in our context that we get data from different sources. Because that's the only way to get this full picture of what's happening with mortality. Thank you.
Yes. Well, we are quite happy to have the CHAMPS sites potentially coming on in the 2 locations in Nigeria. I think first point is it would be, of course, useful, however limited it may be, to have some exemplar population level surveillance sites, which is what these 2 will be. We are quite aware of the data gaps that we have. Interesting thing is what has just been said about the context in Mozambique, but the reality in general for vital statistics and cause of death or mortality monitoring is whether community or health facility based, we're actually not doing well in any of them. And if we had reliable health facility data, obviously that can be interpreted with the appropriate caveats in place, but yes, to indeed obtain the full picture, it will be useful to get a sense of what's happening in communities. And this is why I found some of the data already shared from existing CHAMPS sites quite useful. We would welcome that level of granularity, even if it's in 2 locations, because it's context-specific data, and of course it's easier to generalize rather than what you get with sparse data and fanciful math models. So we, from an NPHI perspective, despite our remit in more of the EPR field and, well, specifically for communicable diseases, we will welcome very much the additional data that will come out of the CHAMP sites when they take off, and we will welcome the opportunity, of course, of using those platforms for additional bits of work and even indeed commissioning more research and even investing domestic funds to answer specific questions as may be required. The other point to add is because you're generating data on child mortality, which covers, remit of pediatricians and generalists from the clinical perspective, but even departments of maternal, neonatal, and child health within ministries. Of course, in Nigeria, I would advocate that we include the relevant parties quite early from the day. But in you want to early exposure to the data, you want to create demand, and you want to make sure that the potential consumers of your data are fully enlightened from the beginning, not from the end. Thank you.
Great. Why don't we move on to our next question? And Dr. Hailu, can I pose this to you? How can NPHIs best use or act on CHAMPS data in the
how does the data that CHAMPS is generating inform some of the health policies that you're thinking of?
Thank you so much. In Ethiopia, there is, under the Ethiopian Public Health Institute, we have the National Health and Health-related Data Management and Analytics Center. It collects data. The center collects data, analyze, and produce the policy briefs and results or outputs from different sources, and often present the data to the Minister of Health. We have different data sources. Within the Ethiopian Public Health Institute, we have the surveillance data for many of the communicable diseases, including the all causes mortality data and the maternal and prenatal mortality surveillance system data from all health facilities across the country. So we have also other platforms, this health and demographic surveillance systems, which are often run by the universities, but the National Data Management and Analytics Center, in collaboration with the regional health bureaus and the universities, collect all the data, have access and mandate to collect the data from all sources and analyze and periodically produce reports and policy briefs to the ministry. And specific to the CHAMPS data, the National Data Management and Analytics Center, in collaboration with the Minister of Health, the Policy and Plan and Policy Directorate, and the Maternal and Child Health Directorate, often just analyze this data, conduct kind of briefings to the wider audience, the regional health bureaus, other stakeholders, the partners working in improving maternal and child health services. So the policy brief that was produced by the NDMC, that is the National Data Management Center of the Ethiopian Public Health Institute, was presented to the ministers at higher level, and that important findings from this surveillance system is integrated to the annual policy, the annual plan of the ministry, and we just developed indicators to monitor and evaluate the progress. And this is a way we use this the research findings, the surveillance data, as well as data from other sources to improve the maternal and child health services. Thank you.
Let me turn to our panelists online. Dr. Natalie Mayette from South Africa. This question is for you. Can you talk about how the social behavioral sciences aspect of what CHAMPS does has been useful to your population, or how do you think that type of activity could support some of your NPHI needs?
Thanks, Lindy, and good morning to the panel and to all the participants. I think, as Elisha has mentioned, and in the South African context, 20% of deaths occur in communities, and they're unrecorded and undocumented. And for us to understand the reasons why women are not presenting to our formal healthcare services, we need to then unpack and use a behavioral science, social sciences to understand what's driving the behaviors that preventing women from going into the formal healthcare service. I think there are a number of predisposing factors that put women at risk. So things like teenage pregnancy. We need to understand the drivers behind teenage pregnancy. There are a number of all of those predisposing factors in terms of malnutrition, food security, exposure to chemicals, toxins, our institutional readiness, that are all going to determine some of the social determinants that need to be addressed. And I think these are key issues that we need to discuss in our communities and use that information to put in interventions, but it's also a tool to determine whether our interventions are actually going to be working. And what's the interventions that's going to have the highest impact in terms of reducing childhood mortality. Thanks, I'll stop there.
Thank you. Dr. Tamina Shirin is also on the phone from Bangladesh. Is there anything you would like to add to that or to one of the questions we brought up earlier about use of the data?
I mean, you are talking about the data that we are getting from CHAMPS.
Mm-hmm.
Okay, actually, you know, where I am working as the director, this is a National Public Health Institute, the Institute of Epidemiology, Disease Control and Research. So we belong to the government. And the thing is that the data that are generated from the CHAMPS the project on monthly basis, this data is uploaded at our website, that is the government website. So this is one thing. And another thing is that we have 2-3 monthly, we have the coordination meeting, we have the technical committee groups. So it's easy to disseminate the data among us. And one thing is that I would like to share with you, we have already started training on data to policy thing, and it's supported by the CDC Foundation. And we already, as you know, that this surveillance is started in Bangladesh since September 2017. It's around 5 years. So we have a lot of data that is generated from Bangladesh. Now we are planning to develop the data to policy, and we have already selected 2 topics. That's the stillbirth and the asphyxia, which is the most common cause of death of the newborns and neonates. So we have already selected this topic to make to transform this data to action or to policy, and to present it in front of the policymakers, and to make the changes. Because we have now looking at the gaps that the cause behind this child and maternal mortality. So some areas are identified. So addressing on these field, we would like to disseminate this thing in front of the policymaker to bring some changes in the community clinic or at the field level healthcare facilities. Over. Thank you.
Thank you. Another question for any of you. During COVID, CHAMPS sites did, and the staff, the facilities, the resources helped out with COVID in a few different aspects. How is that kind of surge capacity useful going forward for planning, or is that is there a way that research groups can be more supportive of your emergency response activities?
I can go first. Yeah. Okay. So I think the first one of the first things that we had as a need when COVID came was to boost the capacity to diagnose. And there were a few academic labs in the country who had a reasonable setup to do PCR testing. And we tapped into those laboratories to help us. And one of those labs was the one at the CHAMPS site. So we had to do some investment in some of those labs especially in terms of biosafety, because some of these research labs do not, they do have the equipment, they might not have the kind of biosafety setup that it's required for some public health testing. So with a little bit of investment, we managed to bring them on board, and they were very helpful in the first phases of the surge of COVID, and that bought us a lot of time to set up other labs in non-academic labs to do that. But in the first few, I would say maybe 6 months, they were very helpful in getting a boost in our diagnosis. So I think this really provided an opportunity, perhaps for the first time in our context, of bringing academic labs closer to public health. And that's, I think, was a very good experience and has increased our collaboration.
Just I would like to add that still not part, but this seems to be yet another option where the cross-utilization of the available human resource that has been trained, whether the diagnostic side or whether the vaccination side, I think this can be strategized, and this will make things easier at the governmental level. As just to share that, as I already said, we have a network of lady healthcare workers and so many other sources that have been utilized during COVID. And that is one of the reasons that today Pakistan stands at 90% of fully vaccinated people beyond 12 years of age, and 95% are partially vaccinated, and 37% have already got the boosters. And we launched the first scheme that was quite tedious for the children's side COVID vaccination with 5 to 11 years of age. And for the first campaign, the target was 8 million, and we attained 97% of the target. And this is just a cross-utilization. So I think once we get nurtured for this CHAMPS in the country, there will be much more successes for the country. Thank you.
So well, I mean, I'll speak from two perspectives. So in the early days of COVID, for most of 2020 and 2021, I lived in Kenya, and I lived in and worked out of the Kemri Wellcome Trust research program in Kilifi. So obviously there is great utility in leveraging or cross-utilizing available facilities. So we served very quickly in terms of providing technical support to the government for the response, serological studies to get a better understanding of cumulative exposure in the population. And of course, we were a regional reference testing center for COVID, both for diagnosis and even for sequencing. And we even provided sequencing support for the island countries of Africa, so Comoros and the like, through WHO. So speaking from the perspective of Nigeria, also in the early days of the pandemic, there were a limited number of laboratories in country that could be leveraged for the purpose of testing. Some of them were government labs, like the National Institute of Medical Research, whose director is also here. But we also had non-government or private labs, and for that were also brought on board. So for the upcoming CHAMPS sites, we would be keen, I mean, obviously as part of being involved in the work that they do, but we will recognize them immediately as collaborating sites and potentially leverage whatever capacity that may be built on sites to serve in some of the things that we have to do in general.
Okay, great, thank you. Any questions from the audience, either for our panel or for the data I presented? Yes, go ahead. Oh, do you need can somebody help us with the mic situation?
Thank you so much. Very interesting data and findings. And I think probably we have to get some take-home messages out of that. But I was interested in the finding that a good percentage of those who had Klebsiella or Acinetobacter were not delivered in hospitals and facilities. Would that draw our attention to the animal component, the zoonotic part? Because both of these are known to live either in chicken or in cats or on plants. So I think one important message that one can get is that when we do screening, we are not taking care of the animal part. I mean, we continuously concentrated our efforts on the human part, but we did not pay attention to the other part. Now, the other question that I have is that Actually, it's not a question, it is a note. From our perspective in Jordan, at least, we know that women, 99% of women get prenatal care from the public services, but when it comes to delivery, only 50% go and deliver in public facilities. And it's partly because of the quality of services that are provided. It's because of the trust or confidence that they have in the provider. So this lack of connection between the primary care level and the secondary makes a point that we have to work on it in order to improve this, this whole issue. The third is a question from your, I don't know if you have costed this, but if we want to use this as an alternative surveillance method, what is the cost per case identification as compared to the already used technologies, methodologies? And if we want to use that cost, where would we put the money, in which approach we would put the highest amount of money? And the last thing is that, was it easy for you, because we are talking about something that might be used by other countries, to take samples of tissues, of CSF, of blood from deceased stillbirths. In certain countries, this might be a big issue, although it had led us to many findings and interesting findings, but we have to think about the practicality of doing something like this on the long term. Thank you.
Okay. Yeah, thank you for that. A lot of good insights. Let me see what I can address. The Klebsiella and the Acinetobacter, we do see Klebsiella in our community deaths, and we don't know what's going on there. It is ripe for more investigation for sure. I'm interested in your theory about the animals. Acinetobacter so far has been hospital related, with a couple of, at least in our data, has been linked to known hospital outbreaks. So thankfully that one is not a community. Agree with your comments on the maternal care. It seems very complicated, but the things that you're seeing in Jordan are not dissimilar from things that we're seeing elsewhere. I forgot the I needed a pen to write down your questions. Oh yeah, the cost per case. The cost per case does vary between sites. This is not a program that most public health places could afford. Now, could it be done less expensively? Yes. Now, if the expensive parts for us are really the amount of people that we need to try to have all this community surveillance to make sure we're getting the community deaths. I think that's very labor intensive. And there are other groups that have done this with just hospital-based programs, and it's much less expensive. You can also use less expensive diagnostics, I think. We do extensive panels with a specially designed PCR multiplex card. You could do this with just looking for some of the top causes, and it would be much less expensive. The pathology piece, also expensive, but again, I think you could use it to be more judicious about what you're actually looking for, and it would not be so expensive. So those are some of the pieces that I would do to cut down the price. And there have been studies of this